As a start, you need to understand why some women need these extra treatments after surgery.
How do you decide what's the risk of relapse and who needs more or less treatment?
In this third episode of the Hormone Positive Health Chat series, we talk about non-surgical treatments and vital tests in treating early-stage hormone positive. Watch previous episodes at Talk Health Asia's YouTube channel.
I think we do see our patients in clinic who get slightly puzzled why they would need an ISH test after having sort of HER2 equivocal. Maybe you could just touch base on that.
So we know that the anti-HER2 treatments or the treatments for HER2 only work for HER2 positive breast cancers and not really for HER2 equivocal or 2+ kind of cancers. Now, we know that a portion of patients who are HER2 equivocal or what we call 2+, some of them can actually be HER2 positive. So hence, we look further into the genes to see whether the HER2 gene is amplified or they are copied over many times in the breast cancer cell. Now, so the HER2 ISH, or which stands for in situ hybridization, or we just call it ISH, okay? If that's positive, then of course, then this is HER2 positive, and the HER2 actually drives the cancer. So we can't really escape from the fact that some patients, maybe about 20 to 30% of patients, will have a HER2 2+. So don't be surprised that you may have to do a second HER2 test, but that is really important because that really decides what treatment is best for you.
Yeah, no, absolutely. And what about the receptors? Can the hormone or HER2 status of the breast cancer change during or after treatment?
And that's a really good question. The answer is yes. Okay. So the thing is, in some patients, we would actually give treatment before the surgery. So for example, we give chemotherapy or even anti-hormone therapies before the surgery to shrink the cancer down, to allow the breast surgeon to remove the breast cancer safely and cleanly. Now, sometimes with the pressure of treatment, these hormone and HER2 receptors can change. Now, the reason also why they change is because, as you can remember in the initial slide, in that mass, you can see different sort of intensities of breast cancer cells. This is what we call heterogeneous disease. Now, an easy way to understand heterogeneous disease is like Malaysia, we have many races. We have Malays, we have Chinese, we have Indians, we have Orang Aslis, so we have different races. So sometimes the different types of breast cancers can be represented in one mass. So if this is the case, sometimes with the treatments that we give, certain types of breast cancers that are exposed to treatment actually die off. And what is left behind may actually be a different type of breast cancer. So in my opinion, after we give treatment before surgery and we go on to surgery, with the remaining breast cancer cells, it's important to actually retest for the ER/PR and HER2, as that may actually change, as the question as someone asked before.
So if we move along, really now just looking at the treatment after surgery, after sort of patients who've gone through breast conserving surgery or mastectomy, what can the patients prepare themselves in terms of treatment after that, Dr. Kiley?
I think as a start, you need to understand why some women need these extra treatments after surgery. Yeah. So I think most of you have heard of patients who have been cancer-free and after their surgery, and then unfortunately the cancer comes back some years later, Now these relapses, right, they are due to remnant cancer cells in the body that are too small to see or even detect on scans. So these are what we call micrometastasis. And unfortunately, they can't be removed by surgery. Okay. Now, so additional treatments like chemotherapy or radiotherapy or anti-hormone therapies, targeted therapies. So these treatments, they work by killing off these microscopic remnant cancer cells in the body to reduce the risk of the cancer coming back, improving the chances or the chance of a long-term cure. So these are termed adjuvant treatments, as what was mentioned by Dr. Nina earlier. Now, so let me talk further about each different type of treatment that we give in the early stage to improve the chances of cure. So firstly, on the left, you can see here chemotherapy. So how does it work? So it works by damaging cancer cells as they divide. Usually in the curative setting, these are given through a drip, and they are given in combination. So usually a cocktail of several chemotherapies are given. Now, what they do is they reduce the risk of cancer coming back in the breast or the lymph nodes, as well, and most importantly, other parts of the body, or what we call distant relapse, so cancer spreading to other parts of the body. Now, how we decide on the chemotherapy is usually based on what is the risk of the cancer coming back, relapse, and usually based on the size and the lymph node involvement, but also on the behavior of the cancer, as we spoke earlier about the different patterns of the ER/PR and certain types of tests that we can do to tell us whether someone needs chemo or not. We also look at how tolerable the chemotherapy is going to be to the woman that we are discussing with. Yeah, so sometimes in elderly patients or those with medical problems that can cause problems during chemotherapy, we generally try to veer away from chemotherapy. Lastly, we also look at chemotherapy in terms of how effective they are. You can see there 1G, which stands for first generation chemotherapy. Now, these are chemotherapies that were generally developed in the 1970s and 1980s. Then the second generation chemotherapies came about, which is roughly about 20% more effective. And then in the last sort of couple of decades or so, the third generation chemotherapies, which are the most effective. Yeah, so that's chemotherapy.
Thank you. I just have a very interesting question from the audience here. In terms of, are luminal definitions routinely used to determine decisions surrounding chemotherapy? And here I'm assuming we're talking about adjuvant chemotherapy in the early breast cancer. And the reason why they're asking that question is there is sort of grayness surrounding Ki-67 testing, which is not standardized in local labs. And then sort of there's operator dependent in terms of grading of cancer. And then there's also sort of cases between moderately strong ER and PR. So how do you determine decisions surrounding chemotherapy?
Okay, like what you said before, the decision for chemotherapy in some early stage hormone positive breast cancers is not easy. It's gray, as you mentioned before, right? In the old days, right? Let's say even back to the 1990s, the answer was chemotherapy for everyone, right? But things have really, really changed because we have now realized that not all hormone positive breast cancers are the same. Actually, many hormone positive breast cancers, especially those that are lymph node negative or with limited number of lymph nodes involved, they actually don't need chemotherapy, right? So this comes down also to what is the behavior of the breast cancer. And there are many tests that we do, or patterns on the stains that we look at to give us an idea whether this woman needs chemotherapy or not. Now, of course, if we look at luminal B breast cancers, they are generally more aggressive, and we would generally favor giving chemotherapy. Now, as I mentioned earlier about genomic scores, okay, so these are useful, okay, these are useful for stage 1 or 2 hormone positive breast cancers. Now, these are the ones that Dr. Nina was mentioning earlier, the very gray ones, right? You feel like I give chemo wrong, I don't give chemo also wrong kind of patients, right? But we now know that giving chemo because just to be sure we give chemo lah, is not the right thing lah, because we have the technology now to better decide someone needs chemo or not. Okay, now so these tests, they look into the genetics of the woman in front of me, of your cancer, your mother's cancer, your wife's cancer, your friend's breast cancer. So it's unique to the person itself, rather than using calculators that look at 100,000 women. Okay, how does this percentage actually apply to you based on this large number of women? But for genomic scores, they are personalized. Yeah. Now, there are actually 4 tests that are in the market in Malaysia at the moment. And they differ in terms of who to use it for, okay, how strong the research is backing the product, and the cost of the test itself. So you can see here, some of the tests are used for both postmenopausal and premenopausal women. But the other 3 tests are generally approved only for postmenopausal women. So for us doctors, we need to know how to use this test so that the information that we get is actually relevant and applies to the woman that seeks our opinion, whether they need chemotherapy or not. In terms of anti-hormones, it basically stops hormone-driven breast cancers from getting estrogen. So estrogen is the female hormone that fuels these cancers. Now, these treatments are usually given as either tablets plus or minus injections, or in some patients, we even discuss an operation to remove the ovaries to render them menopausal. It reduces the risk of local recurrence as well as the risk of recurrence in distant parts of the body. How we decide whether to, as in which types to give, will depend on whether the woman is menopausal or not, and as well as the risk of relapse, as mentioned before. Now, the treatments, as I said before, the menopausal treatments, and then there are the tablets. Now, these are generally divided to AIs, as is stated there, or what it stands for, aromatase inhibitors. And we also look at the duration of treatment. The general acceptable duration for low risk or intermediate risk breast cancers is about 5 years, but sometimes in higher risk breast cancers, we tend to go longer, even up to 10 years. And lastly, as you can see on the right-hand side, there's targeted therapy. Now, these treatments, they target the cancer or they stop the cancer from dividing themselves. For hormone-positive breast cancers, generally these are given in the form of tablets. They reduce the risk of local and distant recurrence. And we choose these treatments based on 2 things. Firstly, the BRCA status. Now, BRCA, for some of you who have attended the previous TNBC talk run by Dr. Nina, it is a gene that can be faulty and that can increase the risk of breast cancer in someone's lifetime. So this is a genetic condition that we usually want to check for, especially for women who present with breast cancer at a young age or strong family history. Yeah. Now we also look at the risk of relapse. So generally, patients with stage 2 lymph node positive or stage 3 hormone positive breast cancers, we will talk to them about the use of a targeted therapy called CDK4/6 inhibitors. So we look at these treatments. These are the treatments that are actually available, and we need to personalize the recommendations to every patient because no patient is the same.
Thank you, Dr. Kiley. I mean, I look at the table and I'm thinking, how do you make that complex decision with the patient in front of you with regards to what's best for that specific patient? So to unpack that, maybe we can first discuss on how do you decide what's the risk of relapse and who needs more or less treatment?
So great question. So risk. Okay, what are the chances? What is the probability of a relapse happening? Yeah. So usually we look at two factors: the patient factor and the cancer factor. So when we look at patients, generally women who are younger age, they unfortunately have a higher risk cancer even by virtue of their age. Okay, versus patients who are older. Why that is the case, we are still trying to understand. Now, it is possible that younger women with hormone positive breast cancers tend to have luminal B breast cancers, but this is still being investigated. Secondly, whether the patient or the woman is premenopausal or postmenopausal. So we know that hormone positive breast cancers are driven by estrogen, female hormones. And women who are premenopausal, they tend to have higher amounts of estrogen versus those who are postmenopausal. So in these patients, especially for high-risk ones, we will talk about treatments to render them menopausal. Yeah. Thirdly is if they have a BRCA mutation. Now, we know that those with a BRCA mutation, okay, are at higher risk of getting breast cancers in their lifetime. But there is also some data to suggest that the breast cancers that they get appear to be a little bit more aggressive and may not respond so well to certain types of treatments like CDK4/6 inhibitors. Next, we look at the cancer itself. Yeah. So from the cancer perspective, I look at from a traditional point of view. So looking at the stage, you know, of course, the higher the stage, the higher the risk of relapse. The higher the grade, the higher the risk of relapse. And we also look at the ER/PR and HER2 patterns. So just now we mentioned if the cancer is HER2 positive and hormone positive, they are at higher risk of relapse. And those who have a lower percentage of ER/PR, which may suggest that they have a luminal B breast cancer, we are also more worried at a higher risk. Then more recently, we started to look at the inside or the genetics or the molecular sort of side of the cancer. So here we look at whether it's a luminal A or luminal B. So we know that luminal Bs are worse, so B for bad, okay? And we also look at certain tests or what we call genomic tests. These tests are special tests that we look in the genes of the cancer that help us to decide whether someone needs chemotherapy or not. Now, we can also use calculators. So this calculator called Predict Breast Cancer from the National Health Service in the UK. So it was designed using very large patient cohorts, patient studies to determine the risk of relapse okay. In this calculator is mainly the risk of death, okay, and the benefit of the treatment you give, okay. So you can see here, you can so in this calculator we can input the traditional things like what is the size, the breast cancer, the lymph nodes involved, what is the ER, PR, and HER2, the grade, and all that. And then what are the proposed treatments that we're going to recommend the patient? And that gives us an idea on how effective the treatments will be in terms of survival. So i.e., how many patients are still going to be alive at 5 years, 10 years, and 15 years. So another useful calculator is called CTS5. Okay, so CTS5 is a unique calculator that determines the risk of relapse after 5 years of treatment for hormone-positive breast cancers. So we are trying to answer the question: which patients are at the highest risk of late relapse? That means relapse after 5 years. Yeah, and this kind of helps us determine for some patients whether we should actually extend the treatment to 10 years or not. So you can see here by inputting some fairly basic information like the cancer size, the grade, how old the patient is, and how many lymph nodes, and give us a rough idea what is the risk of the cancer relapsing after 5 years. So like in this case, it's high risk. So for this lady, we would generally recommend for her to have her anti-hormone therapy extended beyond 5 years.
She's now completed all treatments. So what are her chances to get pregnant?
Normally for hormone receptor positive breast cancer, when they relapse, normally it goes to bone first before it goes to other areas. But
you must also understand that nowadays, many of the side effects we can actually either prevent or treat.
Subscribe to Talk Health Asia's YouTube channel for more health chats episodes, or find easy to understand health videos on talkhealthasia.com.